So, as you said, my name is Chris Weiner. I'm currently the Chief Medical Officer at Derby and Derbyshire Integrated Care Board. So the views I'm going to give you a little bit today are very much personal perspectives, and it's about personal perspectives on workforce issues and the effective tackling of health inequalities. There's probably three areas which I just want to briefly touch upon and raise with people and have them thinking about it as we go through the rest of this afternoon. First one, probably not unexpected to everybody sat around the table today, is around diversity and inclusion agenda. The second issue is about bandwidth of people who are already working within the health and care economies across the Midlands and actually across the country. And the third element is around the focus of attention and the impact of all of that on our ability to effectively engage and tackle health inequalities. So look, diversity. I think as we've gone through COVID, we've as a country, as a world actually, we've really begun to understand far better the fact that actually key voices are underrepresented in many systems, many organizations, and that's true for the NHS settings as much as anywhere else. Okay, so there are people from a variety of different backgrounds who are not well represented in the higher echelons of the NHS. So that may be related to ethnicity, it may be related to sexuality, it may be maybe representative really of other sort of socioeconomic factors. Okay, and you know, people have been brought up in particularly in sort of impoverished backgrounds really when they were very much younger, and their ability to represent their communities in highly strategic roles across the NHS. The NHS is trying to do something about that at the moment, and I think we do need to recognise that. But the reality is we still have underrepresentation from many sectors of our community. And there's a real challenge really about how do decision makers, how do key organisations who are making investment decisions, making decisions that affect everybody's lives, how do they do that truly understanding the needs of their community when people at the top level, at the board levels, etc., don't have a good, deep understanding of the needs of all aspects of their community. So there is something, as I say, about underrepresentation. It's something that does need to be addressed. I think another aspect of diversity, though, is actually recognising that there are issues around opportunity and opportunities within the career ladders within the NHS settings. So let me give you sort of two concrete examples from friends of mine who sort of, and, you know, I know outside of the work setting and one within the work setting. So the first individual I'm going to talk about, I won't name them, but possibly one of the most intelligent people I work with, have known. Okay, very bright person, has a very deep understanding of the world, but is an individual who's brought up in a poor community not far from where I live today, and that individual spent most of his life working as either in a yogurt factory or as a bin man. Okay, and the reason he's worked at that sort of level is because he didn't get any academic qualifications when he went through school many years ago. As it turns out, this guy has severe dyslexia, which, if he'd been brought up in a sort of white middle class family, would probably have been identified early and something would have been done about it. Okay, and probably for that individual, they'd have had much greater opportunity further down the line to take on new jobs, to represent their community, to make their way up the career ladder, because actually they'd have had more qualifications. Okay, but as I say, that's just one individual. There's another individual I've worked with, and this individual is probably in the mid to late 30s now. Okay, again, a very, very bright individual. Again, from a very poor background, poor community. And this individual is another person who did not actually get a lot of qualifications as they went through life. Okay, then they went to school, got some basic, probably GCSEs for their age, not O levels. They're a bit younger than me. I think they got some sort of low grades at A level, but didn't advance beyond that. Now, this is an individual who, in their mid-30s, is currently being supported via the NHS system to complete a degree, and they're doing exceptionally well in completing that degree. But I think we do need to recognise, though, that this is a person in their mid to late 30s, and to progress up a career ladder does require, if you look at things like NHS, job descriptions, etc., to have certain qualifications. Okay, and so this individual, okay, they're being supported now, but they are up against individuals who are, 15 years younger than them, who already have degrees, and so their career expectations, their ability to move into the most influential roles within the NHS is possibly being limited, and being limited because actually, although they're acquiring those further qualifications, they're doing so at a point in their life which actually limits the amount of time they've got to get to those highly influential positions. And I think the third aspect of diversity I wanted to touch upon was a sort of sense of cultural discomfort. Now, there's that old saying that opposites attract. Actually, that's not true. Okay, and if you look at the hard evidence, what we see is that like attracts like. And whether you're appointing a new government or appointing somebody to a new role in an organisation, actually people tend to appoint people in their own image, from the similar sort of background. And we know this is an issue, okay, and we see it day to day, and we see it in terms of where people choose to live as well. Not only the way where people work, but I think we do need to recognise it's an issue. Okay, and all of this, when you sort of add it up, and there's probably a whole host of other reasons as well, all of this affects the diversity of our workforce, and along with that, the ability of our workforce to truly understand the needs of people from very, very different backgrounds to the sort of white middle class background that I come from. So I think we should recognise that up front. Bandwidth. I've called this the under the nose approach. Okay, there is huge pressure at the moment on health and care services, and for at least the past 10-15 years, we've had a sort of 4 to 9% growth in annual demand for health services. That's predominantly driven by the changing demographics, the aging population, particularly those people over the age of 75 with multimorbidity. But this is a huge issue, okay? And when you combine that sort of increase in demand because of the changing structure of the population with things like COVID, okay, what you get is much greater pressures at the front doors of services, whether that's A&E, whether it's general practice, whether it's social care. And what that means is that actually people tend to focus on the problem under their nose. Okay, so when they've got far too many people waiting at their front door, looking for help, looking for assistance, actually they're focusing, how do I get to the end of the day and help the person who's there in front of me right now? And they don't tend to have the bandwidth then to to actually start to think about the wider agenda, and say the health inequalities agenda, and particularly with the health inequalities agenda, the people who aren't turning up. Okay, so we know that actually, the people from a variety of backgrounds, whether they're from poorer communities, whether it's from various minority groups, they access the health services less than people from more well-to-do parts of the community, and people, because they're focused on the pressures at the front door, they're not thinking about those wider issues, and they're certainly not thinking about, okay, so how do we improve access to some of those other groups in the community that might actually need the support more than the people who are actually knocking on our door in the first place. And just as another add-on to that, I think we also need to recognise that we have an ageing workforce in many areas of the NHS. We've got somewhere around 10 to 20% vacancy rate across many posts in the NHS in the country. We know that actually we've got an ageing primary care workforce, with a very significant number of GPs who in their mid to late 50s who are potentially looking at retirement in the not too distant future. We already have gaps in our primary care workforce, because actually primary care practices can't recruit GPs to run their services in the medium to long term. And we've also got clear gaps in urgent care services in our hospitals, where there were difficulties in, say, recruiting stroke consultants, and just to name one particular issue that I'm aware of in Derby and Derbyshire. So we've got an ageing workforce. All of this, though, is increasing all of this stuff, which puts pressure on bandwidth, okay, makes it much harder for people to tackle the health inequalities agenda, because they are entirely focused on what's under their nose on that day. Focus of attention, much of this is actually related to COVID, I think, at this point in time. So we have huge performance issues in the NHS. We've got problems with A&E attendance. I talked about the increase in demand. Well, A&E is one of those front doors which is facing that demand by every single hour of the day. Okay, we have huge numbers of people who are on elective care waiting lists. Okay, and those numbers have grown over the course of COVID, and it's going to take some time, I think, for us to bring those numbers down. We've got cancer waiting times, which are much higher than we'd want them to be. Lots and lots of work and attention at the moment trying to get those cancer waiting times right down. But it is, again, it's a focus of attention at the moment. And whilst we're focused on those sort of issues, it's difficult to then to shift the agenda to tackling health inequalities effectively. And ambulance delays, they're sort of reflection of not only what's going on in A&E, but what's going on, beyond the front door of A&E, in the rest of the hospital, in the social care system, and also prior to that, in terms of what's going on in our primary and community care settings, to try and tackle some of in a more preventative way, some of the issues that we have out in our communities. So, as I say, I think, for me, I think there are three key areas which we need to recognise as having a real impact on our ability to engage effectively in addressing health inequalities. There's clearly the issue around diversity and inclusion. There's an issue around the pressures on the services, which I sort of described that word bandwidth, and there are clear problems around. There's a clear focus of attention on issues, on areas of work, which actually mean that people aren't quite so focused on addressing some of the issues around health inequalities. So I was going to leave it at that, Patrick, and deal with any questions. And